Okay. Okay, we're just going to wait one more minute. We're just going to wait one more minute and let everybody sign in before we get underway.
So you're gonna do the sign in at the start today?
No, we'll do it. We'll do it toward the end of the day, but we're just going to wait and make sure that people get on before we start today's session. I'm gonna let's see. We'll usually wait a minute. 101. And I can see people popping on. So 101. There we go. And people are popping in. So good. Welcome everybody to Hospice Inside of Corrections. Today is going to be we're going to be doing the ELNEC pain management module, correct?
Yes.
Okay. But before we get there, I just want to remind everyone that this is your faculty. When you get these slides, if you need to get in touch with us, please feel free to do so. Myself, I'm at J. Boudreau, LMHPCO. Marquetta, our education director, is at Marquetta at LMHPCO. Today, you're going to hear Lisa Sigsworth, and Lisa is Lisa Sigsworth at gmail.com. You'll be hearing eventually from Ann Walker. And you've heard from Kathleen. If you need to get in touch with any of us, these are our email addresses for future use. I, you, Participating in this automatically makes you a member of LMHPCO. So I want to encourage you, if you haven't done so already, to go to our website, www.lmhpco, your login credentials or your email address and a temporary password has been set up for you, capital P, lowercase ass, 1234, exclamation point. There are, when you do that, you open up pages on our website that are not available to the public, and especially around compliance. We will be posting a new page just for those of you who are here. Will have access to all of these tools that we put together each week for you. I'm building that page for you, and I will be announcing it shortly. It will contain all of these videos. It will contain all of the handouts that we're handing out, plus other tools that you will need or that will be useful to you as you develop your hospice programs within your facilities. It also, when we have conferences and workshops, you can participate in that at member rates if you log in to the website before you register for anything. We will also be setting up a task force on corrections, and I want to invite you to consider becoming part of that task force, where we will talk about things that are important within corrections that can help this organization support your work there. With regards to this series, we are giving continuing education. Today is an hour and a half of actual continuing education credit. In order to do that, you have to make sure that you're here for the entire duration of today's presentation. And at the end of today's presentation, I will be asking everyone to put in their name and their username, their email address right under it in the chat box. But you don't do that until we ask you to do that, and you have to do it before we closed. I noticed some people must have walked away from their computers last week and they didn't sign in. So I just want to warn everybody, you have to stick around for the entire presentation in order to get those credits. Within 24 hours, you will be receiving an evaluation of today's session. It's important that you complete that evaluation in order You have to sign in using your credentials. You complete the evaluation. It's very simple. And once you do that, you get a certificate of attendance that you can download whenever you need to present that that credit. It is kept in your profile. When you sign in, you will see your profile, and any educational offering that you take with us that you get credit for will be stored right in your profile, so that you'll have access to that information at any point. Videos are being done of all these sessions. However, no new credit can be issued just because you reviewed the video. You have to actually attend the session. This is only for you to go back and review any information that you may want to review. Today is the 8th. We're going to be doing pain management. Next week, we go back to a 60-minute session, but the week after, we'll be back for a 90-minute session when we get to ethical issues. So I just want to make sure that everyone understands the lineup for the 11 weeks that we'll be doing this. And of course, I do want to remember and thank the Franciscan missionaries of Our Lady. They're making possible your educational credit. So having said that, I will now turn it over to our illustrious presenters, Lisa Sigsworth, who is sitting in San Antonio, Texas, and Marquetta Lipford, who's sitting in Corinth, Mississippi. Take it away.
Thank you,
I hope
Jamie.
everyone is having, oh, I'm sorry, Marquetta. Hi.
I was just asking Jamie to unshare so that I can.
Yes,
share.
yes, ma'am. Thank you. Oh. Is that unshared?
She started the screen sharing.
Yeah,
Yep, there we go.
Yeah, yep.
Okay. Hi, I hope that everyone is having a wonderful afternoon. Marquetta and I are actually tag teaming a little bit because my jump drive crashed earlier, and so we are using her. So Marquetta, if I raise my hand, that means go ahead and go to the next slide. So we are going to have to go back and forth. For everyone who hasn't taken this class before, ELNEC is scheduled a lot around social workers and nurses. And so some of the information that you will be getting, I'm going to scoot over and make sure that we try to talk as much as we can about what you can actually do in your work in the corrections. And so we will be working with the different ones on the pain management and on your different slides. Some of it you're going to say, oh, this really doesn't apply to me. And you're probably correct. So we're going to be altering a little bit, not a lot, because we're not allowed to alter a lot with ELNEC, but we will be going through that and take in consideration to use the information. This is your building blocks, okay? These are the basics that you can use to be able to build and expand this in your own programs. Okay, Marquetta. Marvelous. At the completion of this, you should be able to identify some barriers for adequate pain relief in serious illnesses, list some components of thorough pain assessment, and describe some pharmacology and non-pharmacology, which is just simply a fancy word for saying, we're going to help you learn how to do some pain management, okay? How and different things that may be able to help someone that's maybe pain with pain control through medication, and also some modules that aren't pain management through that at all. We're also going to discuss the role of the nurse and you as the person that's being with the patient in order to be able to do pain assessment and management in some serious illness. Okay, Marquetta. Is it going? Marquetta, yes. Next day. It's going to make you do that. All right. Now, beginning with an understanding of the patient's goal, their physical function, emotional, and spiritual well-being. This is important because a patient or the person that your loved one that you're working with may not have physical pain, but they may also have functional pain, which means movement, emotional pain, which is the person and their mental capacity of what's going on, and also your spiritual well-being. If your spirit, your emotions, your mental capacities are hurting, then it's going to affect you overall, especially in your physical body. You want to make sure that we're focusing on symptom relief, and that can also be anything from moving someone into a different position and also talking to them and allowing them to talk to you. The management of the symptoms is going to be not only pharmacological, which is a fancy word for medicine, non-pharmacological, which is another fancy word for things that aren't medicine, interventional, which means we're going to be doing something about it, behavioral, which is modification of our thoughts and what we're doing, and also complementary therapies, which means touch, light, sound, different things. Symptom management across all the care setting is accomplished through good communication, collaboration, which is another fancy, and I like to use the word fancy word because sometimes when we're actually sitting here trying to explain what we're looking at is written way up here, and what we understand is right about here. And sometimes the people that we're talking to, they're right here, but sometimes it's just a different level of understanding. So whenever we're doing that, that's what I will do the entire time that we're talking. The coordination between your professionals involved in the care would also not be just the nurse, the doctor, but also the people that's working around them. Okay, Marquetta.
Do next. Sorry.
Yeah, it's gonna make you do that. All right, this is gonna be a
Yep.
short one on this one. Definition of pain. We're gonna be going an introduction, multi-dimensional approach, which overall, barriers or what's keeping you from getting a good pain assessment and also managing the pain. And then we'll go over a case study. Pain is an unpleasant sensory or emotional experience associated with or resembling that associated with actual or potential tissue damage. Let's put that into a different way. What is pain? Pain is what the person tells you it is. Is it hurting you here? What kind of hurt are you having? What does it seem like it? Is it sharp, stabbing pain? Is it grinding? When you stand up, does everything feel like it's about to collapse? When you're laying there, are you able to breathe okay? It could be the potential tissue damage, which is another way of saying what's going on in our body. What it is what the patient or the person says that it is. If they tell you they're hurting, believe them. Is there something that's going on? Could what they're feeling be part of their emotions? Could it be part of their psyche? Is it a spiritual hurt? Is something going on that's making them hurt so much inside, mentally, emotionally, and spiritually that it affects them physically? Okay. And Marquetta, I apologize right now. You know I talk like this anyway. So I'll just try to make sure that I don't keep my hands down when we're doing this. 80% of
No
patients with
worries.
it. 80% of patients with advanced cancer have moderate to severe pain. Now, some of the challenges that we may have is the fear of the pain may be, is my disease getting worse? Does that mean that I'm getting worse? Maybe I'm hurting and my cancer has come back. Maybe it's also a fear of assuming that you're weak, or maybe not wanting to appear that you're weak. You're going to work your way through it. How many people have you seen or heard or talked to that said they're just going to power through? Now I'm going to use air signs, power through. They're just going to go right through and work right through that because they know they can get over it. Is that weak or is that being strong? Maybe they don't want to be a distraction to the person around them. They're afraid, well, I hate to say anything because if I do, they're gonna be worried about me and I don't want them any more worried than what they already are. Maybe, and a lot of people have this problem, they don't wish to be drug seeking and they don't want to be judged because as a drug seeker. Maybe they believe that everything is being done for their pain and nothing else can be done. Okay, Marquetta, beep. Non-malignant diseases and pain, you want to assess for what's going on outside of their main diagnosis. Maybe it's just something else. Maybe they have advanced osteoarthritis. Maybe they've had hip replacements and the weather has really affected all those joints. There's a lot more research that needs to be done on this because usually we focus on the main diagnosis and not the accessories or what else is the comorbidities of what's going on with that. Pain associated with depression in patients with heart failure. A lot of people don't think about heart failure hurting and chest pains, but a lot of times if you're not getting oxygen all the way through your body, other things hurt. Your legs could cramp. There's oxygenation, lactic acid buildup. If you've ever run a long ways or you've had to go a long ways to do something, and then you felt that there were issues involved with your body, that's a pain that was caused by something else. Now, adequate pain relief may hasten death by increased psychological stress. Inadequate. Inadequate pain relief can affect you psychologically. It can decrease your immunity. It can also lower your ability to move around. And studies have been shown that the more you stay in bed, the shorter your life expectancy is. In fact, some of the medications and stuff that we use actually put somebody in bed to keep them more comfortable. Overall, they will be comfortable, but yes, their life expectancy is a lot shorter. It can also increase the non-moving around will cause your lungs to fill up, which causes pneumonia, and also blood clots in your legs. It can also increase the workload of your heart and lungs if you're trying so hard to focus on not hurting and to make sure that you're not doing something, that it can actually increase your heart rate. One of the signs that they look for in an emergency room for someone who is telling them that they're hurting is a change in their vital signs. Now, there's a lot of barriers to pain relief, and the specific barrier, unfortunately, the number one is professionals. It's our own healthcare systems, and then, of course, the patient and the families. When it comes down to professionals, you really want to make sure the education of the healthcare professionals understand what's going on with pain and don't see it as just drug seeking. A lot of times it's overcoming system-based issues. Once something goes into a computer system and they're talking about all the documentation, then what they're looking at is someone that's already been marked as a pain seeker. We also use the current guidelines, but we need to learn to make sure that we look outside of our regular guidelines, use appropriate analgesics, then we want to monitor the outcomes. Is what we're using working? What if it's having an adverse or a really an opposite reaction to what we actually want them to have? Also, the education of the patient and the families. How many, I know I have, and if you've been in hospice for a while, you've heard this at least once. Well, I don't want them addicted to those pain medicines. Oh no, that morphine, they gave that to my aunt. My aunt died real quick after they gave her that morphine. I don't want her to have none of that morphine. So we hear that quite a lot, and that's actually a big barrier. If they've been comfortable enough to be able to pass over and to cross over, that's helped them to stay comfortable. A lot of times if they're hurting and they've been in a lot of pain and they've been so uncomfortable that it would, oh, yep, there we go, that it is a barrier. So working together with the professional staff, working together with the family themselves and with everyone involved in the teamwork, because it's a teamwork. In the corrections, in corrections, you're looking at the whole team working together as a coordinated effort to make sure that they know how and what to report. Now, the goals of pain management is to make sure that the patient stays comfortable, providing that in adequate pain and symptom control. You want to do this to decrease the stress caused by the pain. You want to decrease that stress in the patient and in the family, because if the family is very distressed, they're going to move those emotions over to the patient themselves. Then the patient's going to feel a lot of guilt and try to withhold any information to let them know that they're hurting. So it's kind of like a systematic control. Provide an acceptable sense of control, because the family and the patient both have different goals. You want to relieve the caregiver's burden. The caregiver's doing what they can to make sure that the patient is feeling okay, but then the patient doesn't want to tell the family because they can see what a burden, and they don't want to be a burden. So once you're able to keep someone in a very even keel with being comfortable with good pain management, that will allow them to be able to talk, to strengthen their relationships, to get everything that's going. Your team as a whole will work very well, and it will optimize the quality of life of the patient. Now, enhancing the meaning of life and illness, this provides us with personal growth to be able to move towards the goal, which our goal at the end of life is to make sure that someone passes away with good symptom management and good pain management. Existential distress is the spiritual religious part that we talked about earlier. If you are in pain spiritually, mentally, and emotionally, that is going to affect the way that pain medicine is going to work in your body. So it's an extremely important thing to make sure that the person has talked their talk. Do they need a minister? Will they take a minister? I had the unfortunate opportunity to witness early in my hospice years, and I've been doing this since 1989. So probably somewhere in 1993, 1994, I witnessed a man that had what we would consider a bad death, and it was all related to religion. I had invited, at that point, we didn't have to have ministers on board. They were just if you needed somebody. And hospice was still in the growth spurt, as I would say, getting out there and learning a lot of things about what we needed to do at the end of life. I did what I thought I needed to do with this man and invited the minister over to come and talk to them about what was going on spiritually. I came out later, a couple of days later, saw him, and he was already in the end stages. And I asked his wife what happened when the minister came over. She went, "Pfft." He showed up, invited us to church, and handed us this pamphlet. And she threw the pamphlet at me. And it was at that moment that I realized that at all times, before someone passes away, that is actually something that I want to address, because we wound up having to use a lot of pain medicine on him because he was seriously afraid to die. So from then on out, I made sure that we did the spiritual religious talk with them if they wanted it, because you can't force something on them, because that's also the dimension of quality of life, and it requires the interprofessional approach. And now that we have everybody on board, we can actually bring our other team members in to make sure that they're not suffering at the end of their life. Now, some of the patients that are at risk for undertreatment are children, because they don't know exactly how to tell you and what to tell you, and older adults. If you think of the last 10 years of a person's life with Alzheimer's, you can actually flip-flop it to the first 10 years. So if you're going backwards in time, you can see that the older adults may not have the ability to tell you where and what's happening, especially if they have some type of mental disorder going on, or a neuropathic disorder where it's going in a spot and they tell you they're hurting here, but it's actually in another part, referred pain. We also may have some other issues with nonverbal, and you're cognitively impaired. They can't tell you what's going on. So in your documents, somewhere there's probably now in your pain management, your EMRs, or if you're documenting something called FLAC and PAD and FLAC both are used for descriptions of grimacing, telling them what's going on, you know, flapping around their arms, something that they can't tell you that they're hurting, and they can't give you a number. I can tell you right now, I have a hard time with numbers when it comes down to what's going on, because a number for me tells me that I'm being limited on my ability to tell you how hard and horrible that I'm hurting. One of the things that we have to remember is that we take the information. I may have a 10 for my pain and be able to walkie-talkie, whereas Jamie or Marquetta or even yourself, if you think about it, you may have a 5 and your 5 is my 10. So we have to make sure that we understand where they're coming from on their pain. Patients who deny pain is also an undertreated issue. They'll tell you, I'm not hurting, because they don't want you to think that they're drug seeking, or maybe they just don't want you to know their business. Some people are very private about that, and they'll sit there and would rather suffer. How about your non-English speaking people? I'm learning a lot of Spanish here, and I did a massive boo-boo a couple of weeks ago with one, which I got a good laugh, thank goodness. So did they, and so did my Spanish speaking social worker that was with me. So you have to make sure that you have somebody with you to make sure that they understand and they can explain what's going on. Let's take into consideration cultural differences. Maybe someone in one culture is taught to make sure that they're stoic and that they don't tell you what's going on. How about the patients who have an addictive disease? They were addicts and they don't want to appear as still being an addict, but they're hurting really bad. And they know that you know that they were an addict. So then they're not going to be they're not going to have the availability internally to tell you. But how about what the professional sees? The professional said, they're just an addict. They're just drug seeking. I've had to have discussions with staff members to make sure that they understood it takes a lot more to get an addict out of pain than it would a normal person who's not had anything going wrong. And then you have that ability to make sure that you let them know a diabetic is not addicted to their diabetic medicines. They have to have it in order to function. Now, the last group in here, which is really another one, is the uninsured and underserved. They're not going to ask for pain medicine because they're unsure. Now, in hospice, we have to talk to them about it's okay, we pay for your pain medicine, but they don't want to waste money that they don't want to ask for it. Okay, Marquetta. Now, let's see, does this sound familiar? Lee's a 62-year-old, and he just returned home after having his right shoulder pinned due to a fall. Now, he's having some acute pain. He's 62, but he also doesn't want to get addicted to narcotics. Now, he has a history of congestive heart failure. He can't breathe really well with the emphysema, and he's also a diabetic. His home care nurse notes that all over in the types of pain at the incision site where he had the cut is a 7 out of 10. He has phantom leg pain because he lost part of his leg due to diabetes, and that's an 8 out of 10. And then he has residual post-herpetic neuropathy from shingles, which means shingles likes to go down nerve endings and cause a lot of shooting, burning pain in that area. It has a 5 out of 10 on it. Now, he has a lot of different pain going on, and he actually needs to have different things done. So overall, for Mr. Lee, you would want to make sure that you treated all those pain medicines. Your pain medicines would be different types for the different ones, and overall, they probably gave him some hydrocodone. Also, some acyclovir to be able to run the hepatic pain out and to lower the pain in that. Now, how does culture affect pain assessment? Are they speaking in their preferred language? Are you able to talk to them in their preferred language? How literate are they with health? Do they understand what's going on? Are they afraid of pain medicine? What is their concept of pain and suffering? Some religions allow you to be able to have pain medicine. You need to know what their religious background is. Are they allowed to take certain medications? Or do they think that that's part of what they should be doing is pain and suffering? Now let's label it correctly. What's pain versus hurt? Now, is that chronic or acute? Do they say, well, I'm hurting here? Is it the same? Ask the patient, are you hurting? Or ask them, are you in pain? See what the differences are for when you're working with somebody. How are they viewing their pain? As a hurt, as a suffering, or is it pain? Ethical responsibilities. Assessment and treatment of pain is a basic human right, yet 80% experience acute unrelieved post-op pain. A lot of that has to do with our new guidelines for pain and pain management. A lot of physicians are now afraid to give out pain medicine because they don't want to get in trouble and they don't want the DEA coming after them. 25% of the residents in nursing home receive no interventions for pain management at all. They may give them a Tylenol, and then they may come back later on and ask them, or they may not come back at all. Unrelieved pain may result in requests for medical aid in dying. So we want to make sure that we are treating everybody accordingly and making sure that they remain comfortable and their symptoms are controlled. Now, what is our responsibility? When we assess and pain management is an ethical and legal principle for all nurses, a lot of times the patients and their families will tell the social worker and their volunteer if they're hurting. It's then their responsibility to report to someone so that they can make sure that they get adequate pain relief. Now, the ethical tenets that are allowed throughout this is beneficence, duty to benefit, non-malfeasance, duty to do no harm, autonomy, the right to self-determination. It's how they view things. And then justice, equal and fair access to pain management. Now, the pain history when you're talking to someone, is it acute or chronic? Is this something that just started, or have you had this long term? Part of the physical examination, whenever you're talking to someone, from the nursing standpoint, they're going to do a physical examination and say, where is it coming from? And a lot of times we can also use labs and diagnostic evaluations for these things. If you're a volunteer and you're working with someone in corrections, then you're going to talk to them about, is this something that's new, or did it just start? If it just started, then you go tell someone about that. Say, hey, John's down here. He wasn't hurting a couple of hours ago, but now he's in there and he's grimacing and he's crying and he's bent over. There's something going on. Or maybe when you talk to them, hey, Joseph is down here and he said that he's hurting. It seems like he's not really doing anything now, but I think it's the same pain he had yesterday, but somebody might want to come look. Now, when you're determining your pain diagnosis, you need to find out, and we as the nurses will find out the etiology of pain to report to the physician. So that's etiologies mean, where did it start? Is it something that's right out here on the outside, or is it internal? Is it long-term, short-term, or acute on chronic means that you have severe pain that's also now worse than it normally is. And then, is the medication or what we're doing, is it working? That's all that interventions mean, is what we're doing working or not. Now, if you're talking to someone about their pain, you want to find out where it is, how bad is it, what kind is it? That's quality, which means sharp, stabbing, burning, icky, itchy pain. What's going on? Temporal factors is, can it be moved around? Aggravating or alleviating means if you move your arm, does it hurt worse than it normally does? Or if you move your arm up and down, or your leg, or you're twisting, is it making your pain worse? Now, the past and current, what you taking for your what are you taking for your pain? Are you moving around? Are you able to do the non-pharmacological? Is, did you put some heat on it? Did the doctor say heat or ice? Maybe we can just move you onto a different mattress. The integrative is, maybe if we're able to, let's listen to some music. Have you taken a deep breath? Let's breathe in and out and focus on something else. So it's integrative, is using different modalities. Pain assessment also means the meaning of the pain. What is going on? Are you having associated symptoms? Are they throwing up? Are they holding their arm and tendering it, which means they're holding on to it really hard and they don't want to move it? What if they've fallen and they function and you notice that their hand is now drooped down? That's a reportable. Maybe they broke something or cracked something up in here hard enough to make their arm where they can't move it. The risk assessment is, what did they actually have in the past, if they've used drugs or alcohol? Is there something that they harmed themselves at during that time? What is the risk of them being able to do anything more with this? Is there a family history and what's going on? Is there a history of abuse? We have to be able to put that as part of our risk assessment, but we shouldn't let it color our risk assessment. And then putting together the goals. Our goal is to give you enough medication. We start low and work high. You never work high and work lower, because that doesn't work. So you want to start low at the lowest appropriate dose for someone, and then build on that, and then see if it actually works. One of the things that we also have to make sure that we know about is that Caucasians do not always have the ability to synthesize certain opioids and codeine type factors. if you look at someone, you can't tell if actually what's going on internally with them either, to make sure that we understand that a lot of us are mixed. And so we process medications differently. So it's important to make sure that we know when we're talking to someone and assessing them, what's going on. The precipitating factors is what happened to make it worse. What quality are we looking at? What region or radiating pain is it going to? How bad is it? What's the severity? And is it something that can be moved around? Now, physical examination of the patient, and you're walking in, and if you're actually in corrections on this one, is that when you're working with the volunteers and with the different people are in there, tell them to watch and look for observation. Look at them. See what's going on. Do they look different than they did before? What do they look pained in the face? Do you notice that there's something that's going on? Are they tendering something? Do they not want to talk? Is it that they're actually sitting there so upset that they're having a hard time breathing? Maybe if you're the nurse in there and you've got someone that's come in there, you palpate the area, which means touch it, and you auscultate, which means listen to it, and maybe you push on it and you pop percussion just a little bit. Is it something different that's going on with them? Now, sometimes, not all the time, especially in palliative care versus hospice. In palliative care, after you've done all the previous stuff, you might want to run some labs and diagnostic evaluations, which means doing x-rays, CTs, maybe an MRI to see if there's something else going on. Rule out if there's anything different that's causing that pain. Maybe you might need to get a few more things done to be able to tell what's going on to get a firm diagnosis. Now, you always want to reassess and make sure that what you're doing is working. Is there any changes in the pain? Or is the medication that you're using working, or is it making it worse? Make the pain visible. And what it means by making the pain visible is looking at it and getting in your mind when you're looking at somebody, what type of pain is this and what's going on? Where's the puzzle pieces for this? Where and what do we need to do in order to make this puzzle appear and where we can actually work on either fixing it or alleviating it? Now, communication is a vast, underused modality. A lot of times it's our fault, their fault, everything around us fault to be able to know what's going on in communicating. We're told a long time ago we have 2 ears and 1 mouth for listening twice and speaking once, which means hear more than you speak. If we're actually able to hear what the person's telling us and understand what they're saying, communication can improve the pain management. They are describing the location, the intensity, the limitations, and what's happening with what was going on. They need to be able to describe the effects on the function on how can they move. We need to document the medications, was it effective, and what kind of adverse effects it was having. Always ask for suggestions, but always be ready to make recommendations, and always be objective. This isn't our pain, it's their pain. Now, in our pharmacological therapies, we have non-opioids, which means they're not narcotics. We have opioids, which could be certain types of narcotics. We have adjuvants, which actually make the narcotics work better. And then you have the routes of administration, which is a fancy word for saying, how did you give it to them? Are you giving it to them by mouth? Is this a shot? Is it creams? Where are we going with this? Acetaminophen, which is everybody on here knows, Tylenol. The Tylenols. Analgesic and antipyretics, they will help with fevers. High doses, however, can cause liver dysfunction, and you have to be cautious with medications in your older adults because you need to know what's going on with their liver. Now, non-opioids or NSAIDs is antipyretic, anti-inflammatory, and analgesics. A lot of these are your Motrin type stuff, and I'll use some of these regular words so everybody kind of know where we're going with this. However, in high doses, it can be very toxic, and they can also have adverse effects on your body. So you also have to watch these with certain medications. Now, most commonly used opioids in palliative care is buprenorphine, codeine, fentanyl, hydrocodone, you know these as Norcos, Lortabs, hydromorphone, Dilaudid, methadones, which are used a lot of times with people who are coming off of heroin, but it's also a very good one to use with bone pain. Of course, we have morphine, oxycodone, Percocets, your oxymorphones, tapentadol, and tramadols. Most of these are the blocking the release of the neurotransmitters, which means that it's putting a block in between where the pain is and your brain and your motor neurons so that the processing of the pain doesn't go back to your brain and process it as pain. The unfortunate thing with some of the codeines and certain things is that certain types, some like certain Caucasians do not process these correctly, and it goes to the happy site instead of the pain site. So they may be in a lot of pain and telling you that they're not hurting, that they're still hurting, but they appear to be extremely high. Bupropion, propofine, blah, I hate this word. That has always been one of those. It's one of those, back. It's a partial agonist. It is used for pain control and medications and MAP programs. It can be tablets, strips, injections, and a transdermal patch. There's less risk for respiratory depression, and it's much safer for those that are in renal. We may go over these really fast because some of these aren't anything that y'all would have any ability to have any input on. Your nurses definitely would when they're talking to the physicians. Methadone, the positives for that is oral, can be liquid. There's different things. It's inexpensive and it's very good for neuropathic pain. The challenges are it's oral, it's liquid, and it's inexpensive. It's useful for neuropathic pain. However, you also have to make sure that it meets the DEA regulations, and sometimes it's very hard to get in certain areas. Now, the adverse effects of the opioids, it can cause respiratory depression. Whenever someone's panting really hard, we may use this for to help lower the respirations, to keep them comfortable and relaxed, and it's very good for that. It does cause constipation, so we have to make sure that we have them on a bowel program. They can be overly sedated or just sedated enough. Sometimes they have to make the determination whether they want their loved one comfortable or do you want them asleep. It's one of those that, are they comfortable enough to be able to sleep? Yes. But if you take it off of them, then they're crying in pain. It does cause urinary retention. Some levels can cause nausea and vomiting. Pruritus means itching. It can cause itching, and myoclonus is jerking.
Hey, Lisa, I think you got a hand raised.
Okay, I can't see it on my end. Yes?
It's Jamie, and I was just wondering from the participants today, are all of these drugs known inside of corrections, or is there a formula? Does your current formulary include all of the drugs that Lisa is describing?
We do not use all of those drugs in our formulary.
Yeah, Don, can you tell me which ones y'all are using?
That's one I'm going, that's on my list of things that I've got to work through, and find out what we're going to have available. So I don't, I can't tell you everything that's going to be on the list. We do
Right.
use, we do use the Norcos, we do use oxycodone. There are times that we use fentanyls. But again, it's something that I need to nail down to know what we're going to have in our formulary available to us in this setting.
Right.
I anticipate there are going to be some things that we're going to be able to use in a hospice setting, from my past experience, that we may not be
available, that may not be available inside of your institution.
Yeah.
Yeah. And I'm just wondering on the Louisiana side, anybody, are all of these familiar to you all, or are you restricted in terms of the pain management agents that are available in Louisiana institutions?
Most of these medicines are available. We tend to
Okay.
focus on the narcotics.
Yes, sir.
And the delivery mechanism is IV, IM, or PO tends to be
Okay.
more important than which specific drug we're using.
Okay. Okay. Thank you. I just wanted to make sure that we weren't talking about things that were not familiar inside of corrections.
And that is important. I kind of, the disclaimer on that is trying to make sure some of these you're probably very used to using. And so I was skipping over a couple of them because I know that they're in palliative care and used in pain management clinics rather than pain control in the hospital versus what you would probably be able to get a hold of. Um, some of it, like these parts on the adverse effects, you're gonna see some of that anyway. But it's a building and it's an information to be able to build on different things. All of these, I think, Marquetta, they have the ability to pull these slides back so that you can actually go in. I like feedback on here to make sure that if there's something in here that you don't see on there, we can actually build into our next one.
I
Thank
just
you.
want to say, if you ever have an issue or question about pain management that you can't get an answer from in-house, please feel free to contact us and we'll get a pharmacist to help you from the outside to think about some of the alternatives to when you're having pain and you don't have something to address that pain inside of corrections.
Yeah.
Right. Okay, ready for the next slide here?
Yes, I am. Yes, thanks.
Alrighty.
Okay. Now, opioids definitions, we'll kind of go through a lot of these. Substance use disorder. In corrections, you're probably working with an awful lot of people who already have a background in substance use disorders at some point, but by the time they get on hospice, they've been in for a while. So that's probably not a large consideration on here. However, our bodies have a tolerance tendency and a memory tendency to be able to know what happened, different things with our bodies. We have to make sure that do they have an addictive personality? Is this something that their body doesn't and is not processing correctly? Like I had mentioned earlier, with certain ethnicities, and I'll just use Caucasians on there. You couldn't look at me and know that I am technically across the board defined as a Caucasian. However, if you were to run my blood, I'm technically internally African American or African because I have to be utilized separately a way that I use my medications and I have to be flip-flopped. So we have to make sure that when we're dealing with somebody and working with somebody, well, I hate the word dealing with because it seems like you're dealing with a problem. And it's not, it's actually a challenge to be able to learn what the puzzle pieces are. What are your puzzle pieces that are going to go in and work appropriately for these people? What are their tolerance level? My tolerance may not be Jamie's tolerance, may not be Marquetta's tolerance. We each have a different tolerance and ability to work with what's being given with us. The physiological dependence is also different with each person, and it builds on the medications that we're able to use and tolerate in our system. So it's important to be able to be continuously review what's happening and to monitor everything. I know shortly or coming up pretty soon in hospice, we will be making sure that every time you change a pain medicine, can't make a phone call, you got to make a visit, which we did anyway, but certain times you have to make sure that you're right there, what's going on, because it's easier to be able to evaluate something one-on-one than making a phone call or making a call or taking the information from somebody else. Did someone have a question? I thought I heard something. Was someone speaking? I had a question? No? Okay.
No, I think that was me, Lisa. You did
Oh,
it.
okay, all right. All right, all right. Drug overdose is the leading cause of death amongst those under 50 years of age in the US. The challenge is, how do we reduce pain and suffering and contain the toll of harm caused by misuse of opioids? And how do we prevent unintended consequences of the effort to control this misuse and protect access? Now, in corrections, it is a confined environment. So in the confined environment, you have a little more ability to control access to opioids and what's going on with opioids. Now, we also have the ability to make sure that you are going up and down and altering the medications so that you don't have somebody that's telling you that they're hurting when they're not, because vital signs are going to be a big indicator of what's going on. Your flat pads are going to be able to tell you what's going on with that patient and give you a good snapshot of the puzzle that you're trying to put together. Okay. Marquetta. Now, one of the things that we have been having a lot of help with in the use of pain management is also your antidepressants, your tricyclics, and your serotonin uptake inhibitors. Those help to work with the psychological parts of pain. Your adjuvant anticonvulsants, your anti-epileptic medications are very good for neuropathic pain, such as your gabapentin and pregabalin. Gabapentin works very well. You can work that in with your pain medicine to help make sure that they're spasming, making sure you keep that into a controlled part along with your antidepressants. The antidepressants helps with what we had discussed earlier, is a lot of times, not a lot, a big part of your time, what are they having going on mentally, emotionally, and spiritually? Working with antidepressants and also the epileptics help to maintain a better overall sense of the puzzle of being used with pain management. Topical, I know that sometimes some of this is available, maybe not. So your topicals would be your lidocaine gels, lidocaine procaine creams, lidocaine patches. Good old fashioned Vicks has been used. I had one person tell me they just put Vicks on everything. I said, okay, I haven't used that as a pain management tool, but it says, if you tell me that works on you, Vicks it is. IVs, and then of course, in the hospital setting, you can also use spinal, which would be completely alleviating the pain by completely cutting off the neuropathic pain controls to that area of the body. There we go, menthol and camphor, diflinac gel and capsaicin. That's your tiger gel, tiger balms, the different ones that actually work. Good old Bengay. The different things. If the other part is, did they tell you that it worked? If they told you that Vicks worked wonderful, then Vicks works wonderful for them. It may not work for you, but if they have it in their mindset that that's something that works, it's going to be able to help them somewhat. Because a lot of times it's mind over matter. What did they tell you worked? If that worked on this part and they knew that they liked Tiger Balm or Bengay or the different ones, and it worked good at one point, try it. Doesn't hurt. Now, your corticosteroids are very good. You have to watch those along with your diabetic management, and it can actually increase their appetite. You have to watch for a muscle wasting. You usually want to use that in the morning because you want to keep them up at night. Your orals, will also mess with your sugar levels. So you just have to be careful and cognizant. However, corticosteroids and the steroids are wonderful for keeping swelling down in an area, increasing the effectiveness of your medications. That's what helps to be able to make them work in conjunction with each other. Now we'll just skip right on over this one because I'm pretty sure that y'all can't use those. And that's a lot out here in the world. We're still getting used to having to add that one in anyway. Now, I know that we had talked about, you can get the oral, you can get the IVs, you get IMs. A lot of your oral medications and your high levels can be put right here in the gum. We use a lot of sublingual. Morphine can be inhaled through an inhalant type, which works wonderful for people who are having problems breathing. It can also be used, just like Lasix can be, to knock fluid off of somebody really quick. Most of your pills can be given rectally. If they can be given orally, you just have to make sure that they have a high enough temperature in that area, and also to make sure that they don't have diarrhea, because it doesn't work at all if they do. Transdermal is your patches. Sometimes you can actually get your topical creams and put something on top of those in order to make sure that they absorb correctly. IV, sub-Q, and IM medications. That means IVs in the vein, sub-Qs directly underneath the skin. Intramuscular is just a deeper type of pain of injection. Epidurals and intrathecal catheters are usually reserved for in a pain management or a hospital setting. That's practice. Okay, Mrs. T is an 86-year-old. 2 days ago, she fell and broke her hip and had surgery. Now, she's got a lot going on. She's a diabetic. She's got heart failure. Her kidneys are not doing well. And she was just diagnosed with stage 3 colon cancer 10 months ago. Now, on our assessment, we found lots of places of pain with a score of 8 for incisional pain, because she just had that surgery. And so she's having morphine continuous with no breakthrough. And the surgeon has said, I'm afraid of overdosing her. Our response would be, well, we need something to help her with pain, because we're not going to be able to do anything. Now, in the correctional setting, you've had somebody that's come back. They're 86. They just had their hip replaced, and they've come back to you. They got a lot of stuff going on. They're diabetic, heart failure, renal failure, got a lot. And they've also been diagnosed with colon cancer. Now, they're also telling you that their pain is at 8 at the site of the incision. So as you're palpating it, you're looking around, you want to make sure that the site is not red or inflamed. If it's red or inflamed, what kind of antibiotic do you possibly need to put them on to get the inflammation down? You probably want to look at an NSAID, but you have to be very careful, because they've got renal problems and heart failure. And so you don't want to force them into something else, but you might want to look at a possibility of a steroid. Nope. What's going on with them? They're a diabetic. So you have to make sure that you adjust it and possibly have them put on a sliding scale if you're going to use a steroid in that area. Now, the surgeon has said he don't want to overdose them, so they didn't really discharge them back to y'all with anything. So you'll have to talk with the doctor about making sure what's going on, what can we use, because you're going to have to either A, get them up and get them walking around with therapy or something to be able to make sure that they're going and doing, because once they lay down, they sometimes do not get back up. Now, the principles of pain management, you want to make sure that you're titrating or moving that dose around to the optimal level without overloading their system. Start low, work up. If there's an adjuvant that you can use that can increase the effectiveness of that pain medicine, then that could be actually used. What are your long-acting medications? Are they on a long-acting extended release medicine? You want to make sure that you move things around to give yourself a better option of having better pain management. Do they or did they have a substance use disorder that's caused them to be more tolerant to the pain medicine that they're being given? If they're tolerant, then that's going to be an adjustment that has to be done, and they're going to take more than you would. If this is acute versus chronic, acute pain medicine management would be different from your chronic pain management. Your acute needs to be given, and you titrate it down to where you get them out of what's going on with them. Interventional therapies, what's going on that can be used outside of the normal usage. Pain, can you use heat or cold? Is there something, maybe you have a stim system that you can stimulate or to be able to do something with them to get them out of the acute phase. In the non-pharmacological techniques, maybe you can use light, sound, music therapy. Is there something else? Guided imagery. I because I'm a hypnotist also, I like to use hypnosis with them to be able to get them beyond your normal guided imagery. And then what is your role in being able to help them? Is your volunteers able to make sure that they distract them long enough to be able to talk to them, or is their talking actually distracting them itself? I've had to talk to some of our volunteers about making sure they weren't overly chatty. Some people just aren't talky. Now, if you're going to do the titration or the extended release versus the long acting release medications, find out which one works and works better. Don't be afraid to adjust those doses and talk to the doctor. Hey, this isn't working and I don't want to go higher on the breakthrough medicine. Breakthrough medicine, they've got these things going on. They can't have an awful lot because they get kidneys and liver problems. And we're seeing some side effects. So can we go with a longer acting one? Of course, we have the immediate release is the morphines, the liquid morphines and the Dilaudid can be given really quick, goes right in really fast. But then you want to make sure what type of breakthrough pain is it? Is it the chronic pain that's gotten worse? Or is it the acute pain on top of your chronic pain? So distinguish what kind of breakthrough pain it is. When you find one of the opioids is ineffective, even with adequate titration, change it up. Don't be afraid to change it up. So this is not working. We're going to try something else. Use when the adverse effects are unmanageable. Maybe they're having way too much constipation. Maybe they're having too much nausea and vomiting. Maybe there's something else that's going on and you notice that their their output is going down. Then we're going to have to change it up a little bit to see what's going on. Determine the equal doses of what's going on, and this would be your ability to work with your pharmacist and find out, because all of this part right here, you're going to have to get with your pharmacist to see what's equal analgesia is getting something that's working the same across the board, and you can't use this one, so you got to find something else that works the same way. So if you're using morphine and you find out they're just itching way too much, and then you find out they had a minor irritation or minor allergy to morphine at one point, what is the equal analgesic to Dilaudid? What are we changing it over to? So your pharmacist is the key person right here to be able to adjust everything down when you're looking at changing drugs. The treatment of pain in persons with a substance use, you want to make sure that you're really working with the interdisciplinary team, setting realistic goals. What is your actual goal with this person? And then setting limits. Using non-opioids as you can and considering their tolerance level. You want to work with your specialist, and in your interdisciplinary approach, see what's really going on. Because sometimes you do have people that are sitting there looking for that high, looking for that's going on. So it takes the team or it takes the village to be able to figure out what's actually going on. You want to avoid injections if you can, but sometimes it's not possible. You also don't want you don't want to have people go through withdrawals. And this is, excuse me. You don't want people going through withdrawals. So you want to make sure that you treat depression and other psychiatric disorders and make sure that they are all managed well. Use the alternative opioids if they're on methadone for maintenance. The methadone can help with that. Always remember to use universal precautions when you're going through with anybody who has substance disorders. You already know what's going on with these patients. You already have their history. And so using that history to make sure that you have certain diagnoses don't actually process medications correctly. So always keep that in your mindset. Okay, Marquetta. Cancer therapies to relieve pain, which sometimes this is an option. You'd have to send them out for radiation, sometimes surgery. Radiofrequency ablation can help with tumor pain. Chemo, immunotherapy, hormone therapy. Bisphosphonates is not going to be an option probably, but some of the other therapies may be something that you could actually look into, but that would be a send out. Neurolytic blocks, neuroablative procedures, all of these are going to be something that are usually in the hospital and people that would have to be sent out for. Non-pharmacological strategies. Physical would be rehabilitation, moving them, get them moving, exercise, heat and cold. The TENS unit is something that we talked about. I mentioned earlier is the TENS unit, the little one that goes back and forth that you attach with pads. And of course, cognitive behavioral therapy is mind over matter. What's going on? Can we relax? The psychosocial, meditation, hypnosis, music, biofeedback, and systemic desensitization, which means that you're teaching them not to pay attention to the area that's hurting. Your complementary and integrative acupuncture, Qigong. Qigong is a Japanese, Chinese tradition of different mind over matter, which actually could work very well with some of your people. It's kind of a different type of yoga. Therapeutic massage, does it help? Does it hurt? Reiki. Reiki is also an energy field, working with energy fields and laying on your different Christian beliefs on that one would be also laying on of hands, energy. Then you can also go with virtual reality. That is visualization. What is going on? Can you visualize yourself as a healthy person? Can you visualize the pain receding? Working with people to make sure is it flowing in, flowing out. So there's a lot of different things can be used in complementary integrative health. Pain relief is contingent on adequate assessment and use of both drugs and non-drug therapies. Pain extends beyond the physical causes to other causes of suffering and existential distress, and it takes the team to be able to recognize what needs to be going on and to report to each other, hey, this is working, hey, this is not. Maybe we could try something. The integrative therapies can be added in to be able to give you an overall of something else to help keep someone comfortable and towards a pain-free or a less pain management and less pain than what they normally are in. And always remember to listen to them.
I think that takes care of the PowerPoint.
Do we have any questions or something that we can kind of go over that you had some questions or maybe one of the slides that we can kind of see how it would help you to be able to work with these slides within corrections?
Lisa, I think the overall approach to what you did is very good. It covers a lot of different areas. And one of the things I look forward to working with our volunteers on are some of the non-medicinal modalities that you've talked about. And I've been at this long enough. I've dealt with enough patients in enough different circumstances that I know that sometimes the non-medicinal modalities can be very effective, or paired with medicines. Maybe you have a patient, if they're, if ideally their frequency is once every 6 hours, and they hit that 4 to 5 hour mark and they feel things starting to come back. Sometimes those distractive modalities can be very effective in getting you to the point that you're able to go ahead and give the medication again. And there are, they can all be paired together. And I think that's the thing that is going to be very important for us to communicate, is that we're not tied to one way of dealing with the problem. You know, just like there are many different sources of pain, there are many different sources of remedy.
Yes, and you're very right. There's so many other modalities. The Qigong, using yoga and stretching, especially with people who have Parkinson's, and they're adding in something with that. It helps to stabilize their core, to be able to help them to move so they don't shake as bad. There are the modalities of the guided imagery and the hypnosis where you can actually help somebody completely. There's in hypnosis, there's a thing called glove therapy, which actually is the ability to numb an area completely by using your mind over matter. There are things that we can use to be able to calm ourselves with different modalities to make sure that if you're upset, if you get anxious and you can't breathe, well, what happens? You can't breathe even worse. And then what happens? You're in a big, huge circle of anxiety. The increased anxiety causes more pain. So if you put something in there that can cut that circle, then it helps an awful lot.
Ron, you bring up a real great point because remember, this is a team effort. It's the
Yes.
IDT, and everyone on the team has a responsibility, not only in terms of assessing pain, but how every member of the team can um, help in the amelioration of that pain. Whether it's
Yeah.
because as Lisa was alluding to, sometimes the pain is psychosocial or spiritual in nature, and it is being manifested as it's physical pain, and oftentimes it's the chaplain and the social workers who are just as much involved in pain management as is the nurse and the physician.
You know, keeping in mind that we are not limited to one particular modality.
Exactly.
You know, basically it's a holistic approach.
I'll give you an example. Your hospice volunteers are going to play an integral part in eliminating a lot of pain because they're going to be doing things with the patient. They're going to be keeping the patient socially involved, playing checkers, taking their minds, playing cards, doing all sorts of things that are going to help the patient not concentrate on the pain and the misery, the suffering that he or she might be going through at that time.
Yes.
The understanding that a volunteer may have a level of trust with that patient, or the patient may have a level of trust with that volunteer that they may not readily give to the nurse or give
Yes.
to the doctor. You know, and that's why the IDT interaction is so very important. Sharing those things that have been learned and including those people in that process.
I know this. These series, it focuses on nursing and medicine, but these apply whether you're the chaplain or the social worker. We could replace nurse with IDT member, a
Yeah.
volunteer. All of this information applies to every. Even security and classifications should understand these principles. Again, security is going to be key to a successful hospice.
Thank you.
We've
Yeah,
had
and
some
it's
pretty good results with pet therapy here. We actually have some inmates that raise dogs, and they
Oh.
always brighten up the mood when they come around.
Exactly. Yeah, there are more ways than just giving a pill to people to help them relieve their suffering.
Yeah.
This is about recognizing the difference between pain and suffering and understanding suffering.
Yeah. It's extremely important to be able to be open to the different ones. I love the pet therapy. There's
Yeah.
light therapy, there's music therapy. There's so many different ones that can be added in as an adjunct to be able to help someone to get past that. And the trust thing is exceedingly important because there is a lack of trust amongst the inmates to be able to go and look and to be able to talk to someone, but they will talk to a peer because the peer is there for almost the same reason they are. So if they're there, they're going to trust, and that trust is extremely important. But it's also our responsibility to make sure that we keep that trust at the same level, and make sure that they know that we are discussing that. You don't want to break the trust amongst the inmates either, amongst themselves.
And an example of that is pain seems to be most acute at night when people are trying to get to sleep, when there's less activity, when their mind is less occupied with the activities of the day. Just another example that there are other ways of handling pain than simply a pill. It's the active involvement of that patient in their care.
I'd just like to say that, the inclusion of the information in this PowerPoint presentation hopefully sharpens our awareness to the idea that there are so many different types of pain, thus many, many, many ways to assess as well as provide treatment to that pain. And of course, that's both inside corrections and outside. So I think as professionals, as parts of an entire interdisciplinary team, it behooves us to be able to understand these modalities and how they're indicated and what we can do to help alleviate the various types of pain in all of our patients.
I was just wondering, do any of the chaplains or social workers have any comments about what you're hearing with regards to managing pain in your role?
I'm just thinking about when I worked at the hospital and I would sit in huddle and we would constantly talk about the different ways that as a chaplain I could go in and help, and then we would schedule things. And even seeing around here at MCIW, just those moments that truly, and a chaplain arrives or a field minister arrives, there's a difference in just the way everybody kind of walks and breathes a little, because there seems to be a little hope that's walked in, especially with those field ministers. So I think that interdisciplinary is what's going to help change so many things, including just outlooks and how it all processes through.
Exactly. Thank you, Beth. That is so true. I can't stress the importance of this team, the delivery of care through a team as opposed to an individual. Any social workers on that have comments around pain and pain management today?
Hey, Jamie, this is Claire at Hunt. James and I were just talking about how, we can see where it's so good for us to have this information because we can help advocate for the guys, or especially here at Hunt, we have a lot of people who, when you were talking about it being the cues, the nonverbal cues, for someone who with their mental health or their physical health or their cognitive ability isn't able to explain it or, describe their situation as well as they could. That's the kind of things that we can be on the lookout for.
Pass it along.
Mm-hmm. Yeah, and pass it along to the rest of the team.
And I know there's a natural suspicion inside of corrections that folks are seeking, they're drug seekers inside of corrections. I know that's a natural bias that everyone probably in the medical profession and inside of corrections has. So you have to be able to separate that bias when we're talking about end of life. When we're talking about folks at the end of life, how much is too much? It becomes an ethical question, a question that is eventually we're going to be talking about in 2 weeks with regards to the ethics around all of this. How there are certain principles that we have to adopt in order to understand modern end of life care in this country. So we'll get into that in a couple of weeks after we go through pain, and next week is symptom management, right?
Yes.
Aside from pain, we're also looking at are there other symptoms aside from pain that we address in hospice on a day-to-day basis?
Yeah.
Any other thoughts or questions or reflections before we go ahead and take roll?
Yeah.
Lisa, thank you so much.
Yes.
Thank you so
I
much
want to thank everybody for coming on.
for taking us through that. Marquetta, thank you for your excellent use of advancing slides. And I want to thank everybody who's on today. I want to remind you that the Franciscan missionaries are making this all possible. And I would ask you to go into the chat box right now and put your name along with your email address, please, so we can record that you were here today. And like I said, within 24 hours, look in your inbox. If it's not in your inbox, look in your spam or your junk folder, because it will end up there. All of you who sign in today, we will be sending you the link for an evaluation of today's session. And when you complete that, you will see in your profile is a certificate granting you 1.5 hours of continuing education credit through the ELNEC network. Marquetta, anything else you need from us today?
I do not. Thank you all so much.
Okay, so next
Lisa,
week,
thank you.
yeah,
You're
Lisa,
welcome.
thank you. Next week we will start at 1:30, not 1 o'clock, right?
Yes.
And it's going to be symptom management. Okay,
Yes.
folks, thank you. We'll see you next week at 1:30 Central Time.
Thank
Have
you
a
very
good week
much.
and be
Thanks,
careful.
everyone.
Thanks.
Thank you.